Yeah, thank you very much, Professor Oviedo. I would like also to introduce for the audience other members and co-director of the NGL that are connected with us. Dr. Clemente Junior Napi from Spain, Dr. Andrea Di Santo Albini from Chicago, United States, and also Dr. Federico Mongardini from Rome. And so, if everyone agrees, we can start with the presentation of the paper that we selected for you today. I want to remember to everyone that this journal club was selected on our decision. The paper was on our decision, but the main topic about abdominal wall hernia was selected by a poll that was presented on the TROGSS family. And so all the TROGSS members selected abdominal wall defects as a main topic. And for the second episode of the Journal Club, we will launch today a new poll to select the main arguments. So please, Dr. Charan Purganan, can you start?
Yeah, I can. So I'm just going to share my screen if that's okay. So hello everyone, presenting the manuscript title, the Da Vinci Single is okay. All right. So I'm just going to be presenting this. So the title is using the Da Vinci single port robotic platform in abdominal wall surgery, preclinical exploration of suprapubic single port extraperitoneal approach. So So mainly the presentation it describes a preclinical surgical investigation, mainly using the Da Vinci Singapore robotic platform for ventral hernia repair through a suprapubic approach, extraperitoneal, of course. The goal was not to prove clinical superiority or something, but mainly to test whether this technique is viable or technically feasible before moving into human trials. So mainly they used the ideal strategy, which is so this is would be either in the I or the first part of D, I'd say, in the idea part, because it is parsing the idea, just looking at it. So this is mainly, I'd say, progressing from a dry lab testing to more cadaveric models. So I'd say, so moving on to strengths and weaknesses here. As you can see, the strengths is, it had the technical detail was very, very vigorous. It was really, really great. It explains the exact trocar placement, the retrorectus dissection, the transverse abdominis release, TAR, and the use of SP access port versus a rigid metal cannula, and robotics, which are very important in surgery, instrument articulation and especially Cobra camera mode, so you can look around the awkward angles, maybe avoid them a little bit more. These details make the technique easier to understand, easier to recreate in an actual human trial for the down the line. And the main advantages, I'd say, of this approach are the possibility of performing these complex, extraperitoneal abdominal wall surgery through a single suprapubic access point, while maintaining the dexterity, the endorist, while minimizing the visible abdominal wall trauma. It also may offer ergonomic benefits compared with conventional approaches. But when it comes to weaknesses, it was still very early stage. Only included three cadavers and one pig model. Yes, so the reproducibility and the generalizability are quite less or quite not known at the moment. Very limited. There were no human patients, so safety, recurrence, post-operative pain, wound complications, cost effect, and the true clinical advantage here have not been the lack of quantitative outcomes. There were a lot of things mentioned, but important things such as operative time, instrument collisions, surgeon workload, the pressure issues, and comparisons with the robotic XI model, which is the golden standard right now, or laparoscopic or conventional multiport, were not really evaluated. And but overall, I'd say this is a very strong stage 1 to 2A type of innovation paper, more like a great foundation, I'd say, more great foundation for a good paper for a good future work. But prospective studies are still required to determine the technique is safe, reproducible, cost effective, of course, and mainly superior or at least equivalent to existing repair methods. So right now, I'd like to end this discussion with a few questions. These are mainly directed to the masters, of course. So question number one, would operative times with the SP platform decrease with the initial learning curve? And are there any procedural steps that may ultimately become more?
Please, Luca, can you answer these questions? Thank you very much.
Oh, thank you, Nicolas. Thank you, Rodolfo, for the kind invitation. I'm so proud to be here and with our TROGSS family. And congratulations on the presentation. I'm super happy to answer to this question. Well, I think that modern robotic platforms have more or less the same docking time. So yeah, I don't think that there will be significant differences between different robotic platforms if you have only one docking. I believe that the SP platform would have a significant advantage over the other platforms when you have to redock the robot, because if you have I don't know, if you have to do any tap bilateral tar with the lateral approach, you have to double dock the robot, and this will take time, of course. And if you have the split platform, you don't have to redock the robot, so it will allow a faster procedure. And regarding the question, I think that the procedural steps of the procedure are the same, and I don't think that there will be differences between the platforms because the steps are all the same. So I don't think that there would be any difference.
What do you think, Professor Oviedo?
Yeah, congratulations, by the way, Gerard, on presenting an interesting paper. And you're right, the more prospective studies will be needed to be able to validate this, but at least it was a good feasibility study. And it demonstrated that it is safe to do the procedure this way. Now, the fact that you can do something that it's technically feasible doesn't mean that it should be emulated to do it in all cases. Right. So in this particular case, it worked, but in the future, body habitus, severe obesity, etc., it may not work. And then that's when you need to be prepared to use multi-port, more conventional robotic approaches. So I don't want anyone to leave this webinar thinking that we're advocating for using single port technology for all hernias with the extraperitoneal approach. We just want to, the NGL's intent is to show the audience that it is possible to think outside the box and to do procedures that are very complex with multiple modalities and multiple approaches. And I mean, we could talk about other unconventional, less conventional approaches here, but to answer your question, I agree with Dr. Gordini. The docking time, I think it's going to be fine. It's not going to increase the time. Once you dock, it's with the single port technology, it's very easy to maintain the same approach. What I would say, the main issue here is the indication. So rather than focusing on the technique and the time, let's remember that when we're training, especially we're doing a new procedure, we should not be focused on time. And a lot of these papers, they make the mistake of focusing on time. And time is not the issue here. It's really safety. And it's the technology and it's the technique and it's the ability to perform the procedure in detail and with lower rates of complications. And what is the most important complication we're looking at here? It's going to be recurrence of the hernia. Of course, we could we could injure organs, God forbid. We'd have an injury to to a hollow viscous or injury to the bladder. We're choosing an approach that is suprapubic. But the most important issue here is safety and reducing the recurrence. And the only way to know is to study this population over time. The technicalities, the approach will be similar to multi-port anyway. And just remember that multi-port extraperitoneal, when we do ETEP or when complex hernia repair, is going to be either a lateral approach or top to bottom from the epigastrium looking down towards the pelvis, or bottom to top from the suprapubic approach looking up towards the epigastrium. At the end of the day, Dr. Zucchini, he spent 2 months with me in our ITP center in Texas. He saw it in multiple ways. And I could even advocate for a hybrid approach in which we start robotic and we do a focused component separation approach, which is something I have created and designed and we will be publishing later. A very focused approach without the need to do a major retrorectus flap, just the tar. And then after that, we do it hybrid with a mini open, mini laparotomy approach to do an onlay, and we can reconstruct the abdominal wall. So I know it's a very long answer to your question, student Dr. Ponganur, but we can start the conversation this way and do a little debate.
Yeah, I would like also to ask to Dr. Andrea Di Santo Albini, because he was the mind behind the selection of this paper, which is very interesting, and I would like uh, to say thanks to him because he did a great job in selecting this paper. I think it's very controversial, and as the audience knows and Professor Oviedo knows, we are here to create controversy. You know, we want to discuss, we want to approach in a different way. We don't want to stay as the classic journal club. We don't want to be the common guys that say, okay, the robot is a great thing, is very interesting, but you know, laparoscopy is superior or open approaches. We want to create a debate. So I would like to ask him why he chose this paper and about his experience, because he's doing a fellowship in Chicago under Professor Giulianotti. So maybe he can say his opinion and his point of view about this topic. Please, Andrea.
Yeah, sure. Good afternoon, everybody. Again, thank you for the invitation. Thank you, Dr. Oviedo, Dr. Gordini, and thank you, everybody. So, yeah, why this topic? First of all, I always been love abdominal wall surgery. Among the all great things that we do have here, we have a very large, extensive SP experience, especially with Professor Bianco, who is under Professor Giulianotti. And I tried to mix, when I was thinking about the paper, the topic, I tried to mix what I love, what we have done, and where are we now. So with the SP, we are around now. Our case series with Professor Bianco is around 550 cases. Should be probably one of the largest in the world, and we're about to publishing. And so we have some experience with a single port. But again, as Dr. Gordini and Dr. Oviedo told before, we are not here to sponsor a technique versus another one. We have to be very open-minded and analyze which are the difficulties now. So about this approach, I cannot hide that we already did two cases on two ladies for small, very small, tiny umbilical hernia plus diastasis. We will publish probably a case series. Now we cannot say if it's better or not. Of course, we only have two cases. Of course, we may say that it's feasible, and we are starting to encounter some difficulties, for example. Of course, the technique of the ATAP is the standard technique, so all the steps are the same. But one thing that I was thinking while our guest, our student, was like reading the questions. The indications, yeah, as Dr. Oviedo said, the important point here is the indication, because the first patient that we tried, that we did, in which we did a single port TTAP, was a lady with two babies, and one of them she delivered by cesarean section, right? So she had a cesarean section, and this was the very first difficulty that we encountered, because you're trying to enter by the suprapubic area, and if you have a scar, it's gonna be very, very difficult to find the correct plane. So what helped us? What we call the fishbowl. Now this balloon that you dock, yeah, is called fishbowl because it's like a fishbowl, and this allows you to have like a few more centimeters of space where you can like put the instruments, and then you can enter the plane, but it took like around 30-40 minutes to find the correct plane. Of course, if you do more cases, you will be, let's say, more expert and faster, but maybe, as again Dr. Oviedo said, it's not the timing our goal, because maybe we can arrive to a point to say, well, maybe who has a cesarean scar, maybe it's not a good indication. So we are in a very, very initial phase where patient safety comes first, and we are like exploring. So yeah, I'm pretty excited because this is a very interesting topic, and I would like to know what Dr. Gordini thinks about that and what Dr. Oviedo thinks about that.
Oh, Andrea, I think that you get one measure point, that in the initial steps of the procedure, gaining adequate space is the most difficult, is the most challenging step of the procedure. And by having more space by the fish balloon, you can have the adequate space to work with the robot. And I think that this is one of the major advantages of the SP platform, of course.
I do have another
Yeah.
comment, Dr. Di Santo Albini. Thank you for your honesty. Thank you for illustrating these cases and telling us about this such an important series that will be coming up. I really look forward to reading the manuscript. 550 plus cases is not negligible. That has to be the largest series in the world. And so I think Professor, are you doing that? Tell me the name of Dr. Professor
Yeah,
Bianco. Is that right?
yeah,
Professor Bianco. I had the pleasure of meeting Professor Bianco at least a couple of times when I went to UIC and I was at your laboratory at CITO. It's such an impressive facility. As a matter of fact, I'm in Nacogdoches in my center. Dr. Susana Acosta, who is the co-director of Robotic Time Zone, she's visiting for a few days, doing almost like a boot camp pre-internship before joining UIC as a PGY1 resident. And so she's been to CITL as well, such an incredible institution. And so I can tell you, Professor Bianco has extensive experience, and Professor Giulianotti, obviously. And so I can tell you, as Dr. Gordini said, and we all agree in this case. I mean, we're supposed to inspire debate. We don't have to agree on everything, by the way. And we're gentlemen here. It's okay. We can argue. But on this one, we do agree. It's really the indication. It's because the technique, as you mentioned, Dr. Albini, Di Santo Albini, it's really the technique is going to be the same at the end of the day, right? It's the same ETEP steps. Be careful with the planes. Make sure you identify the medial aspect of the rectus sheath. Make sure that you don't really create such a defect that you're now intraperitoneal. Try to stay in the in the extraperitoneal space. Make sure you develop your flaps properly. Make sure that you're not just pretending that you're closing just the peritoneum and you're done and now you're going to stay extraperitoneal. No, you have to also close and reconstitute the posterior sheaths. Because I have a lot of surgeons that I know that they say, oh, no, I'm closing the peritoneum. I don't need to close the sheaths. Well, what you're doing is you cannot rely on just that tiny little layer of 2 cells of thickness of peritoneum, because what's going to happen is your intestines are going, you cough, your intestines are going to permeate, and now you're going to have another type of hernia that we don't hear about too much. And I was explaining this to Dr. Zucchini, and he knows it very well. We call it intramural hernias. If you look it up in the literature, not a lot of people talk about them, but these are hernias that are in the middle plane, almost like the grilled cheese sandwich, the cheese in the middle of the bread. So your intestine will get into that space, and it's not a transmural hernia. It doesn't go all the way up to the skin, but it's still a hernia. Now you have a disaster. You have to fix it. Now you have to choose how to fix that. And so the idea is to make sure you reconstitute the posterior sheath, and then you place your prosthesis, whatever you want to use, synthetic, hybrid, biosynthetic, anything. And then you also repair the defect, and the indication is what matters. In this case, some people could argue, why are you even doing this? Using this machine to use it for a tiny little hernia. Well, Professor Bianco knows what he's doing. He uses it for a small hernia associated with rectus diastasis, which is a debilitating issue for our patients, and especially in postpartum ladies, on ladies of childbearing age who have already born children. It's extremely important to reconstitute the abdominal wall, because what happens is, what came first, the hernia or the diastasis? Is it the chicken or the egg? We'll never know. It's a philosophical question. Maybe the diastasis began and then it contributed to the hernia, or maybe the hernia is making the diastasis worse, which is even worse with pregnancy. So the indication is important. Now, if you want to know my real projection for the future, gentlemen, my projection for the future, without talking too much, because I know we have other questions to cover, is this SP technology. Think about it. Is brilliant. The SP, the single port technology, for those who don't know and are watching right now, we're not endorsing any particular company or product. We're just saying any technology that utilizes a robotic platform with only one port, one channel, and then the robotic arms and the camera move like an octopus or like tentacles, and they can enter a cavity. And I'm not advocating for SP or Da Vinci, none of that. It's really the technology, the concept. Any technology that has a single channel robotic platform with multiple arms that separate themselves and have flexibility like fiber optics, and the camera can be used in the GI tract intraluminally. And that is also the future. Now you're talking, this is interesting. You can put it in the rectum, do intraluminal rectal surgery. You can put it in the GI, upper GI tract. Now you're doing intragastric, intraesophageal, intragastric, intraluminal surgery. Can you imagine all the procedures you can do that way? We're already doing them. We're doing ESG to a certain degree. We're suturing and it's fancy. Like, can you do it with a robot? That is really where the future is going. To me, just an opinion.
Yeah, I agree.
Thank you, Professor. We discussed this a lot back in the past in these 2 months that we had the opportunity to spend together. I would like to hear first Dr. Clemente Nappi opinion and his experience in Spain, and ask him if he has any questions for Dr. Gordini or for you, Professor Oviedo, about this abdominal wall topic.
Well, thank you, Dr. Zucchini. Thank you, Dr. Oviedo and Dr. Gordini to be here. And also, if Andrea doesn't want to know my opinion, because before you forgot me, I'm joking, of course. I think that they explain very, very well what is the point. The platform is not the matter because also with multi-port technology, you can do this kind of surgery. The most important thing is the indication and also mm, the planning that you have with this patient. You have to see the images, you have to recheck the case and try to prevent all the problems that you can have during the surgery and try to make a strategy to avoid these points. I want to also thanks Dr. Riccardo Caruso, Dr. Valentina Ferri, and all the teams of Professor Dr. Emilio Vicente in HM Madrid in San Chinarro, because they show me how is feasible, of course, because they have a not so large like experience of Dr. Andrea Di Santo or Dr. Bianco, of course, but they have they starting have like I think they succeed 100 cases more or less, that to be a private center is not so easy because of course
Especially in Europe.
yeah, because the insurance doesn't cover the surgery with robotics. So one of these surgery was also in emergency setting, and they have we have like a complicated hernia. We try to approach with a tap with another platform, a multiport, and we succeed to correct a very big defect or more of 7-8 centimeters, if I'm not wrong, with the operation of this kind. And so also think the possibility that you can avoid the patients of the recuperation of an emergency setting with a laparotomy and the surgery site infections and all the comorbidity that can have. So I will try to ask to two best experts here. What do you think about an application of the robotics platform in emergency setting? Because, for example, here in Spain, another interesting point of view, they are trying to do like a case series about the emergency setting using of platforms, and they are showing some interesting results. So what do you think about the release of this platform, the use of this platform in emergency setting?
Well, thank you so much for the question. Well, I think that as the first steps of laparoscopy, anybody that didn't want to use laparoscopy in emergency setting. Now it's like a must. Whenever it's feasible, you should go. You put a porting sign and see what happened. And I think it's only a matter of a mindset. If and of course of sustainability. It's mainly a matter of administration that allows you to do that, because I think that everybody here would have used the robot also in an emergency setting.
I
I
think
do.
I have a specific case, and thank you, Dr. Nappi. This is a great question. You're getting a lot of wonderful experience in Spain, which is another country where this is being advanced. I would say I have a specific case to tell you. I don't even have to talk based on theory. Actually, I had a patient 2 weeks ago, just 2 weeks ago, a lady who had been through 4 hernia by the surgeons before she came to our emergency department. The lady had two major defects all together, next adjacent to each other. Together, the defect about 12 by 7 centimeters, but two different holes altogether. We consider the defect as a complex, right? And then
Sure.
small intestine in the hernia sac, severe obesity, BMI in the 50s. You can imagine smoker, diabetic patient, all of that. What are you going to do? It's 3 a.m., right? And so we ended up admitting the patient. By the time I get to her, we start the case. We do it robotically. We perform a reduction of the defect. We resect the small intestine. We do an intracorporeal anastomosis. We used ICG to evaluate the viability of the ends that remain. Before we do the anastomosis, we evaluate the serosa, we evaluate the mucosa. We're happy with that. We close the mesenteric defect. Then we close the defects. And then I end up using reinforced biologic tissue matrix, and it's safe to use in that setting. It's not really a synthetic, and some studies have shown that you could even use synthetic in that context if there is minimal contamination. It's not synthetic purely, so I went ahead and used it. In that case, I did an IPOM because I felt like that would have been doing something else would have been too much for that patient. It was strangulated. We were already there for an hour and a half. We did the IPOM, and I figured if it recurs in the future, we can always do something fancy like an extraperitoneal repair or even component separation, etc. But we did it. Everything went great. She spent probably 3 days in the hospital, went home. So far, so good. Of course, I left drains, etc., to reduce the potential space because it was a very large cavity where the hernia sac was. And we can talk about prehab and rehabilitation and optimization and all of that. That's why Journal Club is here. My point is, with that particular case, Dr. Nappi, I know it firsthand, even though I don't always get my goal as one of my two directorships here is to be the director of robotic surgery in my hospital, not only bariatrics. My goal is to bring it up to speed, my hospital to 24/7 robotic access, right? But in order to do that, you have to have the conditions like Dr. Gordini was saying. It's administrative support. You have to have staffing. You have to have the willingness of nursing staff to support you and come in and help you with the robot because you can't do it alone. Let's face it, this is not a solo sport. It's a team sport. And so what I'm trying to say is as long as you have administrative support, like Dr. Cordini said, and you have the nursing staff buy in and they support you, they want to go all the way, it's absolutely feasible. I came from a fellowship program in Miami where we were doing 12 to 15 cases a day with 3 teams. Of course, we were using it for emergencies. And really, the best way for administration to advance with this is if you're going to invest hundreds of thousands to millions of dollars on a machine like this, we better put it to work. You're not going to keep it in the garage, right? You have to take it out for a ride on the weekend. So do it, use it, make sure you use it for your patients. The team gets better, everyone learns. Don't use it only for certain cases electively. You have to start using it for more urgent cases. And one way, I end with this, one clever way to do this, actually, Dr. Napi, is maybe not to do it in the middle of the morning hours, like 3 a.m. or 4 a.m. or 5 a.m. But guess what? If you have an add-on case that you need to add to your block time, to your elective day, if you have a cholecystectomy or API or something like that, or maybe something more intricate, not an API, but maybe a ventral hernia, something you need to add, then that's the time to do it. So it's not elective, it's not planned, but it's something during the day that you're adding to the program, or a bowel obstruction case, adhesiolisis.
Yeah.
And then your nurses, the administrators, they all start getting used to it and it becomes normal. It becomes like, I finished my work and now I'm going for a run. I'm going to go exercise. You see, have that mentality of I'm just adding something else to the day. And that's probably the best way to start and justifying having it 24/7 later. But to answer your question, can it be used for emergencies? 100%. It can be. And I believe it should be. Just like you would use laparoscopy for emergencies. So at the end of the day, it's just a technology. And I said this yesterday on my talk at the Ecuadorian Congress. There was an invited from a hospital in Quito, in the capital of Ecuador. And I said this, I'm going to break the paradigm right now, or the idea that we need to show that robotics is superior to laparoscopy. You don't need to show that. Can you really show that oxygen is superior to water? Can you show that you need more water than oxygen, or can you show that you need more oxygen than water? No, you can't, right? It's a philosophical comparison. It's futile that we need. So robotics and laparoscopy are not against each other. They're a part of the same continuum of care that you can provide.
Thank you, Professor Oviedo. Always, when you talk about the robot, you give me uh, these lessons. You know that I really appreciate the 007 weight thing. Now we have the ancient Greek philosophy. So I don't know if I'm not sure that you're in Nacogdoches, or either you are in Greece, in like 500 before Christ era. I don't know yet. You have always surprises for me, and this great point of view, I appreciate.
I'm in the woods of Peloponnesus. You see the forest?
Thank you, Dr. Sophocles. Uh, I would like to ask if student Dr. Purganer has one more questions for our audience, or if you have any suggestion that you would receive from these masters at the early stage of your career. I suggest you. I was thinking when hearing them, and the question that I thought about is, what's the biggest lesson or the biggest suggestion that you would have received when you were at the beginning of your career?
As in me or the Dr. Lucas
No,
Rodini or Dr.
I
Viedo?
don't know if you have any questions like this, or
Yeah, I do.
we can. Okay, please go ahead.
Honestly, my main question would be more general surgery regarding like what what made sure that this was the right calling for you? What made sure, abdominal wall surgery was the right calling? What made sure it's not bariatric surgery or cardiothoracic? What is it that drives you to for ventral hernia repair or something like that? What is the driving force? What attracts you to this? That's my question. What inspires you about this?
Well, I still remember when I was in my residency. I have one of my mentor that taught me to the early steps of hernia and abdominal wall surgery. Then I did my first master's of the Italian Society of Hernia and Abdominal Wall Surgery, and the president was Pierluigi Poni, and is now one of my friends. And he inspires me because the way he teaches surgery, he's so passionate about hernia and abdominal wall surgery. Then I had the chance to do my first humanitarian mission with Operation Hernia, and it was one of my best experience that I ever had in my life. And I suggest all of you, if you haven't had the chance to do that, to do these kind of experiences, because allow you to bring a big, I mean, a big load of experiences of how to handle with a low resources setting. And well, now all the technology, all the new techniques, the robotics, the new materials. I mean, I'm like a fan of technology, so I think that hernia surgery is one of the specialty that is running very, very fast. So these are the reasons why I'm so passionate about hernia surgery.
And
Wow.
Chiranth, have you ever been to Florence, Italy?
Yes, I have when I was younger.
You've seen the David statue, right?
Yes, I have.
Okay, so you see the detail of the sculpture, such detail, the anatomy, right? And so it's just, I think it's that fascination with anatomy, with restoring the anatomy, but not only that, restoring the physiology for our patients, improving their quality of life, and the ability to work with your hands, to be an artist, to be a sculptor, to be a painter, and never being able to achieve perfection, but just looking for it, being in that journey of quest for perfection. Although we never attain it, we do the best that we can. And the ability to be an engineer is that mind of an engineer. You see that surgery is the perfect mixture of engineering and medicine. Think about any other specialty where you can do that. You could argue, oh, well, radiology, sure, you could do anesthesia. I know, but well, all the respect to my colleagues, okay, I love my radiologists and anesthesiologists and GI docs, but okay, you can look at an X-ray all day or an MRI. You can also modify the physiology from the head of the from the head side of the patient, or you could be performing procedures intraluminally, but at the end of the day, we're the only ones who can use our hands to touch those organs or instruments to be able to manipulate that anatomy. And knowing that surgery is not about cutting, people think that we're cutters. We're not cutters. We're not butchers. All due respect to butchers, I love butchers. Okay, so we depend on them too. I love that, but we're not people who cut. Probably the scalpel is, we use the scalpel 1% of the case. 99% of the case, we're not using anything to cut. We're dissecting. We're reconstructing. Some procedures are about removing organs. Other procedures are about restoring and reconstructing, and others are about implanting something. And what Dr. Gordini was saying, abdominal wall reconstruction encompasses all. You remove certain things, hernia sac, or organs that are dead, or strangulated bowel, and then you reconstruct that anatomy and you restore it the way it was intended to be. And then what you do is you can also implant something to augment that abdominal wall. Because of all these reasons, I firmly believe that general surgery is that specialty that you should go into, because you can then separate and divide and super specialize yourself in other entities like thoracic, colorectal, metabolic, bariatric, whatever you want to do, abdominal wall. But at the end of the day, it's a super specialty that encompasses all. And finally, I finished my little thought with this. It's not really general surgery as in general, like you don't know much of anything and you're just going all over the place. It's not. One time a patient in an elevator asked me, what's your specialty? And I was a young attending or consultant, and I said general surgery. And then she said, oh, I thought you were a specialist. And that hurt me. And in reality, it's because we don't do enough communication, we don't do enough marketing to advertise what we do. We need to be better at that. When we say general surgery, I say think about it as in general of the army. It is the specialty that commands the other ones, because we have to know so much and we have to be humble enough to recognize that we can't know it all, and we always have to look for that state of perfection.
Wow. I mean, that was really inspiring. I wish someone had told me this a couple of years earlier. That was really beautiful. Wow. Yeah.
It's never too late. You can still do it.
Yeah. I want to do it more now.
And then one more thing, I don't know if I'm looking in on the platform on Sir John. I've invited everyone at TROGSS to please ask questions, but if we don't have any questions, we have about 17 minutes. I know Dr. Zucchini already had a couple of videos. Why not? I mean, we could even comment on the videos, critique, give comments, debate. We could do
I would
something
like
like that if
to
Dr. Zucchini or Dr.
I would like to ask you something about because your philosophical speech inspired me. And when I started my residency, and obviously you start doing your first procedures, you start studying more and more and more, and I had the opportunity, and I was lucky to have this opportunity to spend the residency with Dr. Nappi. We always asked ourselves, which is the best approach for abdominal wall surgery? Because if you start, I think that when you want the correct answer to this question, uh, it doesn't matter the topic, but I mean, when you have a question, which is the best approach, you should start studying the history. So, studying the history of abdominal wall, we saw that at the beginning we had always open approaches, and first was approaches with tension. Then we moved to the tension-free approaches. Then, after years and years and years, we moved to minimal invasive, from laparoscopy to robotic, now to the single port, and who knows what's next. But we also approach from the open approach. You are approaching the abdominal wall externally, then you can also approach it internally. With the laparoscopy, we start approaching inside the peritoneum, and later on we develop the extraperitoneal approach. So I think that the open approach is the easiest, the first one that you learn when you become a surgeon. Then you want to move to the minimal invasive approach, the transabdominal approach. But the biggest obstacle, I think, is moving from this kind of surgery to the extraperitoneal approaches, because it's very difficult to create a good point of view, to create space to recognize limits and structures. So I would like to ask you if Dr. Nappi and also Dr. Di Santo Albini agrees. We talk about the learning curve for surgeons that already experienced extraperitoneal approach with the multi-port robotic setting to the single port. My question is, how how steep would be the learning curve for a young surgeon, a young resident, to approach to the extraperitoneal approaches, and which are the, let's say, pros and cons about this approach, and how can we develop great skills at the beginning, what we should look for? Thank you very much.
Nicholas, I want only to add a little bit of things, if I can. Well, I think about abdominal wall, the most important thing is respect the plane. So to respect the plane, you have to know the anatomy, the theoretical part, and all of things. And I also want to be little bit like provocating with this sentence. I want to say maybe in abdominal wall learning curve, the open approach, the laparoscopic, and the robotic approach can be complementary to improve the anatomical knowing of the zone. Because if you study and have any operation like an open anatomy, you can touch, you can feel the differences in cost on the tissue and also the resistance. What is the resistance? And also train your eyes to feel this tension that you have in abdominal wall. Well, when you follow with the laparoscopy, if you respect the plane, you respect the anatomy, you can make a very good sharp dissection and avoid the nerve lesion or bleedings or everything that could make recuperation and also the possibility of a regrowth hernia over the hernia. So, what do you think about if we should start or think about the learning curve not only by the technical approach, because robotic, laparoscopic are all technique, are different way to approach the same thing. So how if in abdominal wall we combine this technique to understand better the learning curve, how can change in the residency program or in younger physician or whatever.
Well, I think that you had a great question. First of all, a hernia and abdominal wall surgeon should master the anatomy. This is the very first step to be, to be confident with the abdominal wall. And I think that hernia abdominal wall surgeons do know the anatomy better than other surgeons. I mean, for the abdominal wall surgery, for the abdominal wall, because many surgeons don't even know that about the pretransversalis plane, the neurovascular bundles, and I don't know, the fatty tridents, the fatty rhomboid, and all the masters. Well, we are knowing the abdominal wall better every day. I mean, Miguel Angel Garcia Ureña and David Laurier described the fatty rhomboid after discovering it with the cadaveric dissection, and before that we described only the triangle of Schumpeter, okay, but it's not a triangle, but it's a rhomboid now. This is the first thing that we have to master. Then another step is that hernia surgery is no one size fits all surgery. We have to tailor the surgery with that kind of patient, with that kind of defect, and master all the techniques. We cannot say that we are a mini-vis hernia surgeons by doing only one technique. We have to have a plan A, plan B, plan C, and we are like space cowboys. We have to move between the spaces by knowing them, so we can jump from the peritoneal space, then we can go to the pretransversalis plane, then we have to move to the retrorectus space, and mastering the anatomy is the best suggestion that I can give you. And of course, also having a good mentor is key.
That's right. Not doing it on your own, especially when you're getting started. Have a good mentor with you. One practical way to do it is, I'm not saying do a hernia repair on every patient. That would be unethical. But let's say you're doing a lap chole, okay, or lap appy or laparoscopic, anything. Take a look at the anatomy. Take advantage of it. Go to the upper quadrants, and you can see where you see the 10th rib cage, the 10th rib, right? The true rib, not the 11th or 12th. You see the 10th by the liver. Go there or go by the spleen. And then you see those fibers of that muscle going this way in that area. That's the transversus abdominis. You can see it because it's barely covered by the peritoneum and the transversalis fascia. So take advantage and see where those digitations of the muscle go. And then it starts moving laterally. Memorize that trajectory. See how it goes lateral. And before you even go to the level of the arcuate line, the muscle disappeared from your view because we're built like a cylinder, but the muscle goes really medial. Remember that many anatomy plates have it wrong. The best anatomy books are the ones that have the muscle properly medial. Most of them, they show you this linea semilunaris, they show you the rectus abdominis semilunaris. and they show you that all the three muscles stop right there. Transversus abdominis, external oblique, internal oblique. That is not true. The transversus abdominis is a very medial muscle in the superior abdomen, and then it goes lateral. You're gonna memorize that. Make sure you understand that like the palm of your hand. I don't know all the lines of my hand, but I probably should. But you know what I mean, right? We tend to say by like the palm of your hand. Know it like your face. Know it like the imperfections on your face. Know it like as in we're among gentlemen here. When you shave, right? When you shave or you groom your beard, you need to know exactly where to be careful, right? Ladies could say the same about how they take care of their beauty or their face, etc. So your body, when you're a bodybuilder, when you know your limits of your body, you need to know the limits on the abdominal wall. You need to know where the arcuate line is. You need to know the significance of the arcuate line. Why does it even matter? Why do we say that the contributions to the sheath are more powerful and stronger above the arcuate? Why are they weaker below the arcuate? Why, when you get a rectus sheath hematoma and it's above the arcuate line, is contained within the side where the vessel bled? But why, if it's below the arcuate line, now the blood goes to the other side? Why is that? So learn to distinguish the linea semilunaris, because you know what? If you destroy that line and you go lateral to that line, you will cause an iatrogenic Spigelian hernia. You don't want to do that. Now, if you do, it's like what I say to my mentees. If you do something and it's by technical difficulty, maybe the cases Dr. DeSanto Albini was saying that, I mean, that just finding the right plane on that C-section scar took about 30 minutes, 40 minutes. I believe you, I've been there. And if that is the case, just identify the problem and fix it. You can fix it. The problem is to make something and then there is a problem and you don't identify it and you don't fix it. Now the patient has a complication. So you can fix anything as long as you identify it. And finally, open, like Dr. Napi said, laparoscopic, robotic, the anatomy is the same. That's not going to change. But to answer Dr. Zucchini's question, the natural progression should be you master intraperitoneal or you master open version, what we call an onlay. Just to summarize, let's remember that onlay means the prosthesis and it goes over the repaired fascia on top, like a drone, like a helicopter. Underlay means that you close the fascia, you're inside, and now you put the prosthesis underneath. A sublay, like a subway, right? Like a sandwich, like a subway. It's like a sandwich. It's like the turkey or the ham in between the pieces of bread. Now the prosthesis goes in the middle. That's where we're moving right now. We're talking sublay, retrorectus, extraperitoneal, all of that. Now, when you do a sublay, it could be preperitoneal, but it could be extraperitoneal. It doesn't have to be preperitoneal. It could be retrofascial. There are so many distinct possibilities, but at the end of the day, you need to know the anatomy. You need to know where the prosthesis is going, and if you're doing a component separation, what we call abdominal reconstruction. A component separation has many flavors. One of them is anterior. When you talk, you need to memorize where the limits are. Are you releasing the external oblique aponeurosis? Where are the limits? Where is the linea semilunaris? And if you're doing a posterior releases, you're now dealing with the transversus abdominis. I gave you some tricks on how to identify it. Make sure, by all means, have someone to mentor you. Don't do it alone because it's very easy to get lost. And like Dr. Zucchini was saying, it could be intimidating. You could be fine and very comfortable dealing with intraperitoneal work. You can do open repairs, intra, but when we talk about the extra peritoneal space, that last frontier, that's the Alaska of hernia repair. That's the last frontier, right? So that's where you need to really get familiar with the anatomy. Once you do it, watch a lot of videos, and not all videos on YouTube are good. So nothing against YouTube, but you want to go to a proper channel that has a proper academic background. I invite you to go to places like Stages or Society videos, official, where the videos that are shown have been vetted by experts. Or you can also go to TROGSS. We have a lot of wonderful videos on our library in Sir John. We have videos on our YouTube channel, or I welcome you to go to Surgical Excellence Academy, which is the academy that I founded that does a lot of education for the young generation. Another long answer, but these are just little tips and tricks to be able to get used to that anatomy. And like Dr. Gordini said, we should be the masters of that space. I mean, it's like saying, I don't want to sound arrogant here, okay? Please. But we should be the ones who know more about electrolytes, really, and nutrition than any other specialty. I mean, like we should only be challenged by nephrologists when we talk about electrolytes, and we should only be challenged by dietitians with lots of experience when we talk about nutrition or wound care specialists, because we need to master all of those. And it's not because we're arrogant; it's because the responsibility is very heavy on our shoulders. We carry that weight because no other specialty will have to dominate all those topics. So I hope this is helpful. It's just practicing, practice, and work with a mentor like Dr. Gordini, like Dr. Nappi, Dr. Zucchini. Work with a mentor. Don't do it alone. It's not worth it. And when you're alone, it's because now you're teaching the next generation.
What do you think about that, Dr. Andrea Di Santo Albini? And thank you, by the way, to Professor Oviedo and Professor Gordini.
Yeah, this was very, very inspiring, especially what Dr. Gordini and Dr. Oviedo said about mentorship. I would like to mention, for example, yesterday I was at this Olga Jonasson symposium, and Professor Giulianotti said something very inspiring that is exactly translate on what Dr. Gordini and Dr. Oviedo said. So he said to the audience, somebody knows Leonardo da Vinci because he likes to export our Italian culture abroad. So of course, people said, okay, yes, yes. And he said, but you know what? Leonardo da Vinci didn't born like Leonardo da Vinci. Before becoming Leonardo da Vinci, Leonardo worked in the workshop of Andrea Verrocchio for 5 years. So he had a master, and Verrocchio had a master. So we need to have masters to learn from. And that's a key point. And then we need to study. And in the future, hopefully, becoming master ourselves.
That's right.
Thank you, Andrea.
That's right. I love that. Oh, by the way, Dr. Di Santo Albini, we do have a question. Maybe one of the panelists answer or the moderators is from Dr. Kaviullah Mian from Pakistan. Thank you, Dr. Mian. You're asking, is ETEP, robotic surgery ETEP, the new standard for ventral hernias on the robotic platform? What do you guys think? Okay, I think we probably answered this already. Is ETEP the standard? I would say no. It's just one way to do it out of an arrangement of multiple options to do the repair.
Yeah, I totally agree with. Hernia surgery is influenced by trends, and we face lots of trends in hernia surgery because we pass from intraperitoneal mesh placement, then we had the ETEP, and many ETEPers are now moving to the periperitoneal space. And of course, the indication is key, but we are facing like the garden hype cycle. So once you have lots of the trend is now from IPOM, then ETAP, and then you move to another technique. Yeah.
I think, yeah, I do agree with Dr. Gordini because abdominal wall surgery is like fashion, you know. Now you want to wear a baggy jeans. 10 years ago, we want to wear skinny jeans, and I think it's not just abdominal surgery, but more or less all of the surgery. But other than the indication, I think the most important thing is to understand pros and cons. As we said before, open surgery is the easiest way. You can do it even with local anesthesia or a less weight of anesthesia. So it's easier. You have a faster rehabilitation, especially for older people, or people that who has cardiac or pulmonary problems, like intra-abdominal surgery, minimal invasive surgery, as the great pros that you are minimal invasive, as we said, as the word said. And I think the ETEP takes the pros of both the techniques because you are doing something minimal invasive, yes, but at the same time, you are not going inside the abdomen. So you will not have complication that could happen after going inside a virgin abdomen. So we have two pros, two very biggest and strong pros, but the very big strong cons is that it's very difficult to understand. It's challenging to have a great learning curve. It's challenging to find a mentor. We don't have to hide behind our hand, because this is the reality, especially in some countries. We have we faced, all of us faced older people or that were not mentors, but were just a kind of masters, but didn't want to share their experience with us, didn't want to share the legacy. So there are many things that could be challenging in this world. I think the most important thing, as you said, as we all agree, is studying and find a mentor. But I think the most important thing is to understand what you are doing and take pros and cons, and then in the end, elaborate and decide which is the best technique, which is the best procedure, the best approach for that specific patient. We cannot allow in 2026 to not think about precision medicine. And
To
this
answer the
matters
question, well, I'm
for
sorry, Dr.
everything.
Kini, go ahead.
No,
No, I was going to say, to be fair to Dr. Caviola Mian's question, I think ETIP is a phenomenal way to do things because it's like a, they call it a surgical operation. That sounds like a redundancy, but I'm talking about military, like a surgical operation by operators, by military operators, special forces. You just go in, you get out. It looks like nothing happened. 'Cause if you think about it, you only have three small incisions somewhere, whether you want to do it top to bottom, bottom to top, lateral, like I do, whatever, and you reconstruct the abdominal wall to such degree. You've seen it, Dr. Zucchini, when we do it from the lateral approach, we do a bilateral TAR, and we call it a TAR, ETAR, right? From the extraperitoneal approach, we do a bilateral TAR, even the ipsilateral transverse abdominis release from the same lateral approach. You can do the whole thing, and it looks like nothing happened. You reconstruct, you plicate the rectus diastasis, and then if for some reason you want to go there 6 weeks later to do a chole, it looks like absolutely nothing happened in that abdomen. Like you said, you didn't even enter. And on the abdominal wall on top, nothing happened. And so that is the best, to me, that's the best way to do an operation when it looks like you were never there because you alter the
yes.
anatomy and the physiology the least. But to, to, to conclude this wonderful webinar, and we got to do a better job at arguing. I think we're agreeing on a lot of issues. I think we think alike, and we did not really find a lot of disagreement. And it's really beautiful to be able to learn together and to debate. And we may not have to. And remember, this is a safe space for everyone. We don't have to agree on absolutely everything. We invite. I want to make a very specific call to action to our members from TROGSS. Anyone who wishes to debate, this is a safe space. And we are in agreement. We all agree, but you don't have to agree with us. Please, we invite you. Come to the podium. Let's debate like gentlemen, like ladies. Women are welcome to debate here. We can all show our techniques. We can learn from each other. We can learn from you too. And let's do it. And you know where you can find some elegant techniques that we will be teaching? At Luxembourg. What's happening in Luxembourg? July the 8th to 10th, we are going to have a phenomenal congress. And the faculty will be there. All of us will be there as faculty. And among the things that we'll be teaching are robotic surgical techniques such as abdominal wall reconstruction. So what else? Let's go to Luxembourg. Let's learn together. Let's do ETEP. Let's learn it. And I want to thank you, Dr. Zucchini, Dr. Napi, Dr. Di Santalbini, student Dr. Chiran Puganur, of course, my friend Dr. Gordini. Thank you for this amazing webinar. And I don't want to use too much of our time, but please, gentlemen, close it out of respect to the audience, and let's do a part two. I'm really inspired to keep doing this, and maybe next time we can comment on videos and we can talk about techniques.
Thank you, Professor Oviedo. I would like to thank all of you, all of my colleagues and friends, from NGL members. I would like to thank student Dr. Pungano because he did an absolutely amazing job, and to thank Luca Gordini. Thank you very much to be here. As we discussed before, we will present a new format in the next month that will be how I do it. So we will comment videos, we will teach videos, we will be your virtual mentor to better understand how a procedure is doing, and we can discuss, and we'll keep doing our journal club. So from today, for 1 month, the poll will be open, and then we can all meet in Luxembourg, obviously, and we'll see. Maybe we can have a webinar all together from Luxembourg. Thank you very much.
Thank you,
I
everybody.
love it. Thank you very much, everyone. Hey, I invite all the members to apply to become members of NGO. This is where we train the next generation of CEOs of trucks. Thank you. Thank you, gentlemen. I appreciate it.
Thank you so much for this opportunity. Happy to see you here.
Thank you.
Thank you.
Thank you. Yeah.